since that reporter did such a, well, I won't say, but a job when he wrote the article on the bond program, we probably need to contact him with JR and say, you might want to now report this.
Yeah.
Okay. But I think our board, as a body, I would ask them, I think we owe the staff of JPS applause for that.
Thank you.
Okay.
That's all my report, Mr. Chair.
Dr. Ziegler? From the medical executive staff?
The one was at the quality meeting, we had the bylaws, parts 1 and 2, that was approved at the quality meeting. We still have parts 3 and 4 and the rules and regulations, which we hope to have completed before the end of the year to bring to the board. But at the quality meeting, parts 1 and 2 were approved. The other announcement is we do now have a vice president of the medical staff that was voted on at the last MedExec meeting. Was last Tuesday, and Dr. Schrader is now our vice president of the
Who is that, Dan? Schrader.
Chet Schrader. He's one of the ER physicians. Yeah, he's been very active in bylaws committee, physician excellence committee. He's been involved in a lot of committees. Does a lot with resident education, and he was the overwhelming choice by several for the vice president. I think the rest are for the closed session.
Thank you. Next, department update.
What I wanted to do when I bring up both Diana Prachel and Don Ziegler up here is to tell you, and they'll tell you more in this report, but what we do each month, y'all realize, is that we feature different functions of JPS. Things that are working right, things that we have opportunities with, and things that we need to do differently. One of the things that we wanted to give you an update on was exactly what we're doing in the community to deal with our homeless population. You will not meet a person with any less vigor than Don Ziegler. You'll not meet with anybody with any less energy than Don Ziegler, and a kinder heart for a population that needs us significantly. And quite frankly, not only does that population need us, the taxpayers need us, because if that community is neglected or not seen, it will be a significant cost to taxpayers. So what Don Ziegler is doing and what that program is doing and what Diana Prachel is doing to make things work is pretty significant. And I know that we keep you board members up to date on some of these things, but we want to capsulize it for you and let you know what true worth is going to mean to us, what our program means to us, and in particular, the new approach that JPS is taking to this. So, Diana and Don, thank you very much. You good with the screen?
Working on it, I think.
Okay. We've done better with our homeless population than our IT, because IT, we might have that up here. I saw Mr. Mendenhall look up really quickly. We have homeless people we're taking care of, but we have a blank screen up here. So. Your paycheck will be fine.
We do all take a moment while hopefully we can get that up for you. We can start to introduce Dawn Ziegler. Dawn Ziegler is the Executive Director of Access and Integration. She works very closely with our homeless population, but her passion carries over into so many other avenues of community health. She, occasionally you get gifts, people who come to you who have never been in healthcare but really have a desire and a passion that far exceeds anything they've done in the past. And so Dawn came to JPS during our recruitment for our waiver projects initially, about 4.5 years ago. And she took on a couple of our projects. This is one, and she certainly has not just taken a district project, but she's taken a program and continues to grow it into something beautiful that really is helping our entire community. And I think, when you start to hear about what she's done and the magnitude of that work, I think it'll be very meaningful to all of you today.
So I thought we'd start with a little context. So in Tarrant County, one time a year, everybody goes out and does something called the point-in-time count. And the effort is to try and count how many individuals on that night are homeless. It's one day, it's one reference point. It doesn't necessarily show you the overall picture. But that one night this year, there were 1,938 individuals identified as homeless. So you'll find in your packet a little bit of information that shows kind of the historical change related to how many people that we find. So that 1,901 night, over the course of the year, might mean 6,000 or 7,000, because there's a high contingency of people coming in and out of homelessness. About 20 to 25%, depending on the year you look at, are called what's considered chronically homeless, homeless for over a year. So that means the other 75% are coming in and out of crisis. They're coming in and out of situations where they may have had a job loss, they may have had some critical situation in their life, a breakup with a family member that's left them without housing. So we have the honor of serving these folks, and in a lot of ways, a lot of segments of society, folks are turned away. And one place where you're never going to be turned away is the emergency department. So it's kind of got an interesting dynamic with this population. So I want to talk to you about the impacts and why homelessness is important to us. The rates of mental illness with these individuals are about double of the general population. So you've got a high contingency of folks that are the folks that really, really need our help. 47% of homeless women have major depressive disorder, so twice the rate of folks, women in general. And then when you compare to the general population, they're in poorer health. So not only does housing impact where you're staying, it impacts your health. I did a quick look at mortality before we came in. So a study from 2005 from the Healthcare for the Homeless showed the average age where somebody would die is in their 50s with the homeless population, where it's 78 overall. 50 years old is where we were at in the 1900s. So it's something that we need to care about, pay attention to. So with that, when I joined a few years ago, there was a piece of paper that said, here's a project about homelessness, and your outcomes are about reducing emergency department use for this population and getting folks to primary care. Didn't know what that looked like. My interface with homelessness, I ended up on Lancaster one day, and I went, what is this? Could I ever help these people? And I sat in my car that day, and I cried. And I said, gosh, is there anything I could ever do? And that was about 7 years before I came to JPS. And so it's really been a blessing and an honor. This is the most fulfilling thing I've done in my career thus far. So I'm excited to talk to you about the program. Our program, Care Connections, our goal is to serve 2,100 patients over the course of 4 years, essentially, of program development. These patients are currently experiencing homelessness, so we find folks that are new to homelessness in that 75%, but we also find those folks that have been homeless a real long time and that are frequent flyers, that our police officers know well, our emergency department physicians know as well too. So you have two different kind of groups that we're working with. They, a lot of times, overuse the emergency department for primary care reasons. So there were a lot of concerns. When I first looked at the Cypress Clinic, we have a clinic right across from the Presbyterian Night Shelter. I thought, this is great. We're located right by the shelters. This is wonderful. And there was a fence around the outside, and the fence was not just literal, it was figurative. Because folks that were living on the street didn't feel like they could come in unless they went through the JPS connections process in advance. They had this, they had that. They had this time that was scheduled in advance. And when you're in crisis, you're in crisis. You're thinking about that next thing that you need, that your pill bottle's empty. You're not thinking about this a week beforehand. And so we had to make some changes with how we not only approached going out into the community, but how that community resource was used. So the project itself was to deploy a street medicine team to go out and meet people where they are. We begin primary care on the streets. That may mean in a tent. That may mean at a shelter. We may meet somebody at a community center, wherever we can find them, with our goal to ultimately stabilize and transition into a clinic. We've embedded a nurse into Presbyterian Night Shelter, and her job is to help connect folks with health care and avoid ED visits. And then my favorite is community health workers. I love this concept. So we take individuals from the community that understand the community, and we help them navigate the healthcare system. We help folks understand how to use the pharmacy. We help folks understand transportation. We help them understand how to get their Medicaid benefits and how to progress through our care continuum. So we also have worked, one of the most beautiful things is the collaboration with other homeless outreach services to coordinate care. I went rounding with my staff 2 weeks ago and walked into a session where we had MHMR, the VA, we had Hands of Hope, and we had the MHMR PATH team that all have different niches that they serve. And they're sitting there talking about the patients, and this guy's from the Hemp Hill game. I saw him last week. Well, can you tell him he has an appointment next week? We need to see him over here. And the level of collaboration we're having on some of the most disadvantaged folks that are sometimes not able to transition into our system well is just amazing. We're going to host those folks over for a little celebration and have lunch and just honor the collaboration that's emerged because of the waiver. So what are the priorities of homeless individuals? And this is just my view on life. It's not necessarily somebody else's, but if you're homeless, the first thing you're going to care about is, do I have something to cover myself in personal care, right? Then you might be thinking about food, what am I going to eat? And then really shelter. Shelter's not always the first thing. And so after you've got shelter, you're clothed, you have food, you know where you're going to the bathroom, you might think about engaging at healthcare at that point. So what that means is we've got to be flexible in how we deliver services, acknowledging that there's some foundational things our folks might be dealing with that we need to connect them to. It's not our place as a healthcare provider to do shelter, to do food, to do those kind of things, but it's our place to have the community partnerships to get those needs met so then we can engage in their health care. And so one of the beautiful things that's emerged is really the partnerships we're working with. Routinely we're working with Presbyterian Night Shelter, Salvation Army, Union Gospel Mission, Catholic Charities. There's a group called I Am Waters that's provided water for us to give to our patients. MHMR has been fabulous. We're working side by side with them. Fort Worth PD is actually sending us patients, clients that previously would have been sent to jail. They're calling us so that we can help partner and see if we can stabilize somebody, which is really beautiful. We want to be able to connect folks with services. Day Resource Center, Broadway Baptist Church recently sponsored a gentleman who was homeless and gave him a place to recover for 7 days. They paid for that out of their benevolence fund. And then First Street Missions. So the level of collaboration we have today is wholesale different than it was 4 years ago. We understand our place, we understand our partner's place in the community, and are really working together to treat that whole person and get those needs met. Lastly, a couple of things that I wanted to share with you. This year to date, we've served 1,250 patients. And so this means rounding on patients when they're in the hospital. It may mean meeting them in the community, helping them get to Medicaid benefits. It actually means primary care provided by our physician assistant. What you'll see up there is a picture of Joel. This was from the Fort Worth Star-Telegram. He's our physician assistant. He was a wonderful recruit, and he's from Salt Lake City and has a history in working with street medicine. And so he's really been a benefit, has excelled, and is now promoted to the director of the program. And so both has that medical background and that administrative background. So numbers we're looking at right now, we've got a little bit of time frame, so we've been running about 3 years. 12 months post-intervention, we're seeing about 50% of the patients are reducing their rate of emergency room use. And so we're looking at how do we measure that overall impact to behavioral health services, primary care services, and that measurement strategy so we can come back with like dollars. It would be great to show the dollars, so we'll get there. And then we've also had a 30% increase in PCP assignment of homeless individuals. So it's very important that we get up front, we make that connection so they feel like the emergency room's not their only option. One of the most exciting things that we do, we're going to do this twice a year, is something called Ready, Set, Go. And we let healthcare workers experience what it's like to be homeless. So we discharge you, it's 2 o'clock in the afternoon. Here's your oxygen tank, here's your wheelchair. You don't have ID, by the way, and go find a place to stay. And so it's really great to see master's level folks, even PhDs, try and navigate the bus system, right? And if I were to tell them the hint, I'd say, go ask the homeless guy. He knows how to do it. It's actually more complex than you would ever imagine. And so we want to create an awareness of what the implications of our decision on when we release folks into the community. What does that mean for that individual? How can we discharge sooner so people have a shot at getting a place to stay for the night? And how can we be more aware of what homelessness means to healthcare? So that's happening this Friday. You'll see about 70 people are participating this time, so we're very excited about that. So that was just a very quick rundown of some of the services we're providing. Any questions?
that the program, Ready, Set, Go, has already had communications from the media wanting to cover that and show what JPS is doing. It's one more nice opportunity that communications, our department has reached out and said, these are some of the things that we do, and that has really picked up some momentum in the community, as well as the work that from the pictures that you've seen and the team that we've got. Good folks.
I think what you guys doing is amazing. I have a question is, when we put our team out on the street, do we have enough security or enough benefit just in case they get hurt?
So in terms of security, we work with our police department on tactics to be safe on the streets. They've done a phenomenal job getting us ready for that kind of thing. I'll have to defer on the second question about the liability. I would have to pursue that offline.
Because sometimes we need to take care of their family just in
Absolutely.
case something goes on. That's just one question I have for long term.
Absolutely. That's a very good point.
I think one of the things that you just described, and as you explained to us the program, a good example of what community health is. Mm-hmm. More than just JPS Hospital main campus. That is a good example of community health. You almost think that we're a social service agency.
Is there, I have another question, because we're now dealing with the very, very deep part of social economic here. Mm-hmm. Is there a way that we can track with the police force or somebody to see if over time does the crime actually reduce?
Yes, I would love to get there long term. We're building those relationships to be able to get there longer term, not immediately though.
Right. Or just the severity, because sometimes you can't cut the crime, but if you can take the severe crime down to a misdemeanor, I think we can do a much better job for the community also as well. It's something that we can talk to during budgeting time and stuff like that.
Yeah, that's a great point.
Did you hear you saying crime reduction among the homeless or crime reduction?
Among the homeless. Because sometimes you can take it from a severe crime down to a misdemeanor. It's from a felony or something like that. It's actually, over time, it can solve some of the safety issue also as well.
Okay. The reason I ask that because if I'm not mistaken, they do keep some statistics on that now in the police department. When I served with the Day Resource Center, they had some statistics that they would
Because
use.
it helps with the stigma, right? Because when you see a homeless, automatically you think, are you safe or not? But if you don't, more tendency, you may be able to help out along the way when you see them or something.
Okay.
Thank you.
I want to thank IT for getting your homeless project up, and I want to thank IT for being able to get Mr. Wynn's mic up loud enough not to get reverb. Very good on both of them.
Okay. We're now down to item 9, I'm sorry. Committee reports and actions. First committee is finance, but our chairman of the finance committee is lounging somewhere in Europe or something. We'll not have a report from our finance committee today. Quality committee, Dr. Weber.
The Quality Committee met on the 1st of September. The minutes were approved, they're in the packet. There are 3 or 4 policies that we approved. They were on the consent agenda for consideration. And then there were 4 things that were presented. Dr. Asini had presented the quality officers update. There was a presentation on pre-op procedural safety. And for those that don't know what that is, let me just digress a minute. Prior to operation, the entire surgical team, including nurse, scrub tech, physician, resident, anesthesia, will meet in the pre-op area, talk to the patient, make sure that they're doing the right procedure, right place, right time, and that everybody's on board. That would trickle down to what instruments may or may not be needed, what instrument packs may or may not be needed. And then it's encouraged to have the family there as well so that everybody can participate in the preoperative assessment. This is different from the timeout that occurs once the patient is in the operating room and on the table and usually already anesthetized or have had a regional block. And at that time, the surgical team, the physicians, et cetera, go over it one last time, what the procedure is, what the site is, make sure there's no room for error on wrong site type surgery. The importance of the pre-op procedural safety, I'm going to take a minute to describe, for those that have heard this, I apologize, but approximately 10 years ago, we had 2 airline pilots come to this institution, JPS, to present their thoughts on how airline safety could be translated into surgical care. This auditorium was full. These 2 gentlemen stood up here, gave their presentation, and then asked us to watch a short video. They said, what you're going to see is a number of people passing around a basketball. What we want you to do, audience, is to count the number of times the basketball is passed, and then we'll sort of grade you at the end. Lights went down, video came on. Well, you can imagine, surgeons for the most part are pretty anal attentive, as you might have already guessed, but
Metaphorically speaking.
metaphorically, you're right. Oh, man. So we're Mac sitting here, we're counting 1, 2, 3, 4. Mac and I came up with the same number, which was about 17 or 18, I forget. The lights went back up. 2 gentlemen said, well, how many times did you see the basketball get passed? Well, there were different responses, as you might guess. Way back in the back, somebody said, what about the gorilla? And then somebody else said, yeah, tell us about the gorilla. Well, all the rest of us were counting the basketballs and were focused just on the basketball. We said, what gorilla? And they said, now we're going to show you this video again, but we don't want you to be honed in on just one thing, which is why the timeout is important, because it lets you forget about honing in on one thing. Well, they start passing the basketball, and then somebody in a gorilla suit walks into the middle, walks around. They never touch the basketball. Sort of stuck their tongue out like, dumbass, I mean, you can't, excuse me. And then sat down. And that's when we realized I was all in the pre-op evaluation. Because as surgeons, you get very focused on the patient and what you're going to do. But you need a timeout for the big picture, for the family and for the patient. So I digress. There was then a hand hygiene presentation by Louis Bedford, Elena Bow, and Vincent Doe. This is a presentation that the hand washing, the time frame is approximately 5 years. Now, people would say, that's awful long to figure out how to wash your hands, but there are good ways to do it. But the most important part came from the Reverend. And this is the type of thing, why it takes 5 years. And I'm going to quote you, if I may, with it. Reverend Emerson goes to the other hospitals in Tarrant County because of his parishioners, et cetera, and he probably goes to all of them at one time or another.
True.
there are certain patients and families that he will have to see where he has to gown up, put on a mask, put on a hat, wash his hands, and then he's allowed to go into a room. But what he shared was, here he is doing all that type of stuff, and then a ward clerk or somebody else can come into the room right behind him without doing any of that, saying, well, I just need to get this one signature. What that meant was the whole process just broke down when it came to patient safety and to safety of anybody that was visiting. That's why this hand washing thing may take 5 years, because you've got all sorts of people coming in and out. This requires washing your hands either with foam or at the sink between every single patient visit. And if you have 30 patients in the hospital, it can take you a long time. We are training residents that will have to do this. We will be training nurses that have to do it. So that was the biggest criticism, I think, was why it would take 5 years. If we can get it done in 3, I will be surprised. But it's the right thing to do. And then the last presentation was by Mona Gall. She gave an update on the destination metrics for the district, and we're doing pretty well. That's my...
Thank you, Chuck.
Thank you.
One of the things that Chuck mentioned in the quality report, we still haven't received the answer, is the proper way to wash your hands.
Leaving that up to Lewis and Vincent.
Right. We're still waiting on that, so.
Need a certified
Certified way
instructor.
to wash your hands.
Now, DT shared with us that one or two hospitals, they have a badge that
Right. What they do is they have a badge, the same badge that you use for HR. So every time you go into the room, some of them will alert if you don't wash your hand, so that the patient is the one initiate. How come you don't wash your hand?
it was just more stuff. I'm done, thank you.
Next item is our governance committee report, and the one thing that we did discuss in governance committee and shared that, and Ron and I have talked about this at great length, is moving to roll out again. You know, we all had the clickers and rated where we thought the programs were for our destination metrics, but enterprise risk. And the goal is to take some steps to better educate the board on what that is. What is enterprise risk as it pertains to the operations and the budget for our hospitals. So you'll be seeing more come forward with that, especially within our next retreat.
Steve McCullum would be proud.
He would.
Yes, he would.
He would. Other matters requiring board action, Roman 10, approval of Olympus endoscope capital purchase, Wonder People. Hi, Wanda.
I have 2 items I'm bringing forward for your approval today, and these are both budgeted items, but due to the dollar amount, require your approval. The first is for our surgical center in Arlington, and this is replacement of their endoscopes. We periodically have to replace these scopes due to wear and use, and this is just routine approval. These have met their life expectancy, and it is approval for 2 colonoscopes, 2 bronchoscopes, and a gastroscope.
Any questions of Wanda?
Move to approve.
Second.
Then move to approve.
The second item is.
Wait a minute.
Oh, I'm sorry.
I know you're happy, but we're listening to you.
Should be happy if we're going to be.
All in favor of the motion? Aye. Any opposed, the same sign. Okay. Item B now, go.
All right, the second item is also for endoscopy equipment, but this is for the endoscopy center here at the main campus, and this is replacement of their tower components, which includes their processors, printers, monitors, the carts, the light sources, and their travel cart that they take to the ICU. It's the same situation here, where these are budgeted. However, all of this equipment has met its life expectancy, and it's just replacement of this equipment as we do, period.
Any questions? Entertain a motion.
Move for approval.
Second.
Moved by Charlie Brown, second by Dr. DeVos. All in favor? Aye. Any opposed, the same sign.
Is information of the used ones available for sale?
We usually trade them in.
Some of us at our home decided to.
Well, I don't know why you're pointing at me. Pointed Trent.
I heard Trent's opening a clinic.
The answer would be no.
Dr. Hire has a question.
What is the criteria for something like this coming before the board for approval? Is there a
$200,000 is the main criteria. All real estate and all physicians that come to the board. That's by your bylaws. And board policy.
I'm going to work tomorrow.
Mr. Chairman, as Wanda's leaving, and I don't want to embarrass her, but I can tell you that the report that we heard earlier, the award that JPS received, based on the change in our patient scores, that day turned the corner the day that lady got here.
Yeah, I think that also had to do with you were the keynote speaker for that nurses award. It was interesting, the nurses award function. Trent and I were sitting on the front row, sitting next to each other, and they were giving out awards, and Wanda was the interim at that time. And they gave her the Administrative of the Year award, and Trent and I leaned over to each other and said, "That's the new CNO." Yeah. Absolutely. Okay. Consent agenda, item 11. We have no item, okay. I intend a motion approval of consent agenda.
After its motion, and I'd like to make a comment.
Move approval of the consent agenda.
I wasn't able to look at it. Does this have the gun policy on it as well?
Say again?
Or is that later? Is the gun policy part of the consent agenda?
It is on consent.
Let's pull that, vote on that separately, please.
Which one?
The gun policy.
Let's make sure, Neil, that we point out which one that is.
That's item under BB,
It's on the
K,
Okay,
Okay.
that's the one we pulled.
BBK.
So we will intend a motion, we will pull BBK and address that separately.
Make my comment. I can't find the place on here, but the reason this is sort of close to me is there's a contract in here where somebody wrote in by hand, out in the margin, I believe it was a claim.
That is correct.
I forget which contract it was.
It's the claim contract because there was a reference to JPS when it should have been a reference to a claim.
Here's the reason I bring it up. I was sued professionally approximately 6+ times. All lawsuits were dismissed. I used to get charts, physicians that were being sued for malpractice. Charts that had poor handwriting, poor documentation, or had handwritten stuff into margins that didn't have a cross-out, initials, date, and time, I couldn't defend it. I'd call their malpractice attorney and say, this one I believe you need to settle because I could not defend this in court. The reason I bring it up was here's something in a contract just signed that for me, I'd rather see the initials of who wrote it, the date and time.
Point well
That's just
taken.
my-
Point well taken. The only reason this one got interlicted like that and corrected that way, it had already been signed by the University of North Texas Chancellor in order to save time, and I have the same issue. I'm going to ask that that initial by him be dated. The contract is dated when he signed it, and it will be dated when it's signed by Robert. He will be initialing that today. So, but those are points well taken.
And if I may, Chuck.
But that's seldom. In fact, I'll be honest with you, I don't know that we've had this happen hardly ever.
No, first time
And
I've
I
seen
agree
it.
with that concern, and that's the reason for that. So,
Yeah, Chuck, just so you'll know, the acclaimed executive committee met this past Monday, and it was during that committee, we had the same feeling. JPS did not need to be there. We didn't know if it was inadvertent, but there what? Ralph attends that executive committee also, so we were the ones that said JPS needs to come out. It had already been signed by the UNT side. And again, I think Neil as general counsel, both the acclaimed council approved all these documents, and they're also approved by general counsel for the district. But I agree with you, it needs to get changed.
well, and
Yeah.
what happens here is Robert will sign this and initial this, and then Scott and I will coordinate getting the chancellor to initial that one change.
Yeah,
So,
we wanted to change.
Oh, I agree.
Thank
And then
you.
the second
Dating
thing,
it, right.
somewhere along the way, a claim got capitalized.
Prefer not to discuss that, but let's just say.
I just wondered where, because we were told that down in Austin, it's all
it's
done
not
by a
capitalized.
small a, and then
But
Whoever's idea that was, to make the small a in the formal name of the document, it's just a little too cute. It should just be fixed one place everywhere and do it right. They do it, we don't need to be that cute. It just was gonna cause confusion until the end of days.
DT.
I'm just curious.
My hearing's not too good, and I thought you said catheterized.
no,
Say what?
Capital, it's capital.
no, he said capitalized.
I believe the chair has a motion in a second on the floor.
Yeah, okay. All in favor?
DT.
On the consent agenda, I have to recuse myself from P. My son providing consulting work for their pricing model, so I can't vote on that one.
I can't hear you, DT.
He's recusing himself as to item P
My mic works.
because of his son's employment with that.
No, he's providing the contracting work for Boston Consulting to do pricing for them, so I'm going to recuse myself.
Duly noted.
Okay.
All right.
We note that.
All right. All in favor?
Aye.
Any opposed, same sign? Okay.
We gotta go to.
Yeah.
Okay.
The gun, huh?
Now we'll go to BBK.
Yeah, let me just make a note on this. Our policy as it sits, I think this is the updated policy. Policy statement, which is what we do talk about, right? Says the policy of the Tarrant County Hospital District, DBA JPS Health Network, is to provide an environment that is, to the extent permissible by applicable law, free from firearms and illegal weapons that can be prohibited on JPS property or in JPS vehicles under applicable state and federal law. That's really not our policy. We have armed guards, right? We have armed people that we pay to be here with guns. So it's not our policy to have an environment that is free from firearms. It is our policy, as it's practiced, I think, is to have a safe hospital in the safest environment possible. And because of that, we have people with firearms that are here. Now, I'm not suggesting we need to go into some big discussion about whether the hospital policy should be changed, but I would say that, generally speaking, legal people who have been trained and having a license to carry, make the environment safer than not having people who have been trained and have a license to carry. So if it's a safe environment, if we had metal detectors and we had a policy that said nobody has guns that come in, then you would catch the people who are negligently coming in with their guns. This policy might have some say to something. But when we just say, well, we don't want any free from firearms, well, we're not doing that. And if we back up and say, well, we want the safest environment, I would, and I understand that I may be in the minority here, I'm not trying to make a big stink, but I would say that if we think about this a little bit more and try to make a policy that actually provides a safer environment, then you would want more people who are trained good guys with guns. Because in every event, I think in the last recorded history, 20 years, the the bad events where somebody comes into an area with a gun and tries to do harm, then the length of time that that horrible thing occurs ends when somebody else who's a good guy shows up with a gun. So this policy doesn't stop bad guys with guns. We don't have metal detectors to stop bad guys with guns. Bad guys with guns will deliberately ignore this policy. So this policy does not affect bad guys. Does not affect bad guys in any way. And we're not doing anything to stop bad guys with guns from coming into the hospital, except hiring a few people who have guns. And if somebody said, well, I'm happy to come in when I come to visit and I happen to have a license to carry, I can make the environment a little safer by also having a gun. I know it makes people uncomfortable. I'm not suggesting we have open carry, but I would suggest that we ought to, at some point, in a calm moment, not as a major topic of conversation, but as a minor one, to say, how do we want the safest environment? Concealed carry, license to carry, people who are trained should be welcomed into every civilized area, including hospitals. That's all. We can go ahead and vote on it. I'll make a motion, though, so I move we change the policy. To reflect, so it says, instead of where it says right now, to provide an environment that, as to the extent permissible by applicable law, free from firearms, I would say as safe as possible. So instead of free from firearms, I'd say as safe as reasonably possible. Does that make sense? Say it one more time. Replacing the phrase free from firearms to as safe as reasonably possible.
I'm trying to work myself to do this correctly. I would feel more comfortable if we want to pull this item, that we would refer it to governance committee, and then we discuss it in governance committee, and then bring it back to the board, as opposed to adding some wording.
I withdraw my motion. I think that's a fine idea.
Okay, all right. Because I have some discussion I'd like to express.
Sure,
That's
and
why I'm
governance is the right place for that, I think, yeah.
So do you need a motion to defer it back to governance?
Yes.
I so move.
Second.
Okay. We moved in second that we refer this item back, refer it to governance committee. All in favor? Aye. Any opposed? Same sign. Okay.
They'll bring that recommendation back.
Right, then we bring it, okay, all right. Okay, next on our agenda is report of general counsel.
I have nothing to report except an executive session.
Amen.
Well, we will now reconvene in executive session pursuant to Chapter 551 of the Texas Government Code.
1 hour and 5 minutes.
Do what?
1 hour and 5 minutes.